Welcome to Internal Medicine Grand Rounds. I'm Dr. Kim Williams, Chairman of the Medicine at University of Louisville. And it's our pleasure this morning to have Dr. David Scales, who's an assistant professor of medicine in the Department of Medicine at Cornell. And he's going to talk about the toxins we carry, something that's a very topic that's dear to our heart here at University of Louisville. Before I introduce his introducer, I want to remind everybody that today marks a big change. That is, this is going to be the first day of our research grand rounds. And so if you're hungry for knowledge or food, come to ACB3. And Dr. Roberto Boli will be talking about his research projects, and we're going to do that research grand rounds every Thursday at noon in ACB3, both hybrid and food. So come to lunch and learn, and it'll be a great time. But this morning for Dr. Scales, he is actually a very close friend from Justin Kingery's time at Cornell. Justin is an associate professor in our department of internal medicine, and he is an associate director of the internal medicine residency program. And he's going to do a real proper introduction of Dr. Scales. Dr. Scales, thank you for being here. Justin, take it away.
Yeah, I couldn't be more excited to get Dave to talk to us today. He's one of the most inspirational people I think I've met in the age versus inspiration balance of things. And so I was so excited when they asked me, do you know anyone from up north that we could get to talk at Grand Rounds? There's no question. I immediately said his name. So I'll give you a little bit of his history. It's not very impressive. He started at University of Pennsylvania, school most of us have never heard of, and then progressed on to Cambridge University for his master's in philosophy. That wasn't good enough for him, so he went on and did an M.D. and a Ph.D. at Yale. And that PhD was very interestingly in sociology, which is not the norm for us down here in Louisville. And he studied a very, very interesting thing. I think he was comparing multiple mechanisms of the World Health Organization's ability to control disease around the world. And so I think maybe that was he'll tell us maybe the early underpinnings of what we'll hear about today. Then he went on to residency at Harvard. That's not impressive enough. So he had to pick up 4 languages along the way that he speaks. He's been on multiple, I won't list them all, grants now regarding the flow of information or the misflow of information, if I can maybe coin a term there. I came to know David at Cornell for many reasons, but one of them was also global health. I was in global health there. And he has a lot of interaction with Syrian refugees on the border of Syria and Lebanon, and does a lot of really cool and great work there for the world as well. He's now a member of multiple boards addressing critical issues in medicine, largely revolving around misinformation in medicine and how we can use that to our benefit as well with our patients. You may have seen him through a couple of emails recently. He is now an official partner with the American Board of Internal Medicine on the flow of information in medicine, and is also advising the Surgeon General on the same. He's the chief medical officer for a company called Critica, which focuses on science literacy. I hope you can tell that all this is very fascinating, but I think most importantly about David, and the reason I wanted to invite him, is his work is really great. But I think there are very few physicians left in the world that are as intelligent and as driving and critical for humanity as him, but also are humble and compassionate. We spent many nights at Cornell together where I would come in and not know what I was doing, and Dave and I would work through problems, and he would make me feel like I was the one coming up with the solutions when clearly it was him. And so I think that combination is rare in medicine, and so I couldn't be happier to introduce him here today.
Well, thank you so much, Justin. It's an honor to be here, and I'm blushing from such a generous introduction. And thank you, Dr. Williams, as well, for having me here. I look forward to this discussion. I wish I could be there in person. Despite the fact that I'm based in the North, I do come from the South. I'm originally from Atlanta, and love to take every opportunity I can to get south of the Mason-Dixon line. And so my hope here is to provide you with a little bit of an interesting introduction to information as a social determinant of health. I'll share my screen and we can dive into it, but I do hope to leave enough room for kind of discussion and questions, because I think this is a little bit of a non-traditional talk. It's a non-traditional subject matter, but I think, and I hope to convince you by the end of this talk, that despite the fact that it might seem outside of the realm of what we typically do, we as physicians, people working in environmental health, people working in epidemiology, have a lot to speak to the issues that I'm talking about. All right. So I'm going to be talking today about the toxins we carry as a metaphor to describe how information environments are social determinants of health. As Dr. Kingery mentioned, I have a little bit of consulting to disclose, and also the CMO work I do for Critica, which is funded primarily through the Robert Wood Johnson Foundation. Always need to acknowledge my colleagues, because the work that I do is not in isolation. Jack and Sarah Gorman at Critica, Terrell Starks, a professor of psychology at Hunter College, infodemiologists who I work with, and I'll explain what that term means by the end of the talk. Kathleen Hall Jamieson, a world-renowned communications professor at the University of Pennsylvania, and of course, Robert Wood Johnson Foundation, our funders. So the learning objectives today is, I hope you come away with this talk with a better understanding of the relationship between information and social determinants of health. And I hope you can come away understanding how what I like to call an environmental health approach helps address the issue of medical misinformation. And I hope to, because we're all clinicians, and so I hope you also come away with a way to identify medical misperceptions at the point of care and have a framework for some effective responses. So here's how we're going to go about today. So first, I'm going to define misinformation and information distortion. I'm going to talk about how information environments are social determinants of health. And then I'm going to talk about how seeing information environments as social determinants of health is really important for both public health and clinical communication, to move away from message-based communication to more environmental models of information health. And I hope to give you a couple of tips to help you operationalize that information environment framework. And I'll briefly touch on the work that, the empirical work that we do on community-oriented motivational interviewing as one remedy to addressing information health. So the Surgeon General defined health misinformation in his 2021 report on confronting health misinformation as false, inaccurate, or misleading information based on the best available evidence or scientific consensus at the time. I think one of the things that's very important to recognize is health misinformation hinges a lot on that last term, misleading. And the problem with that is, who gets to decide what is misleading? Something that may be misleading to me is not necessarily misleading to everyone. So there's a lot of debate in this field about how to even to define health misinformation, and some definitions include misleading, and other definitions do not. I like to move away from that debate. And I like to say that misinformation is only one manifestation of what I call information distortion, how information becomes distorted as it traverses our 21st century information ecosystem. And I'll give a couple of examples. So these are cases that I saw, and Dr. Kingery may have seen while he was working in New York, two patients that I saw at Lower Manhattan Hospital. One was a 29-year-old woman with a history of Crohn's disease and active anal fistulas, who presented with multiple admits for an inability to tolerate PO, refusing biologic therapy, but asking for TPN. And also a 58-year-old woman with a history of Ehlers-Danlos syndrome, who presented with multiple admissions, secondary to shortness of breath and acute on chronic lymphedema, who was convinced that all of her symptoms were not due to her diastolic heart failure, but due to her Ehlers-Danlos syndrome. And this included everything from her lymphedema to her teeth falling out and her obesity. Now, the common thread between these two patients was the fact that they had some medical misperceptions. And I'm not in the business of trying to correct everyone's medical misperceptions. But what I did recognize in these patients was that these misperceptions led them to take actions and engage in health behaviors that were not consistent with their health goals. My 29-year-old patient, she was very interested in getting better. She didn't want to be on TPN as much as she wanted to get better. And yet she was refusing the therapies that all of the evidence that we have in medicine shows is very well tailored to helping people with Crohn's disease reach remission. Her concern was that pharmaceutical companies were only in it for the money, and therefore she had no trust in any of their therapies. And the woman with Ehlers-Danlos syndrome, similarly, was so fixated on connecting Ehlers-Danlos syndrome to all of her symptoms that she was refusing a number of treatments and insisting on trying unproven therapies that were recommended to her by some online physician influencers that she had seen. So the key in these cases, and this is going to be a theme that runs throughout this talk, is that when someone's medical misperceptions lead them to health behaviors that are in contradiction with their health goals, that's when I feel as a physician that it's my job to intervene. But this is also an issue in public health. So this is a snapshot of Twitter conversations around a draft law in California in 2015 called the SB 70. Now, this is a draft law that would have enabled anyone in California to exempt themselves or their children from vaccination for any reason that they chose. Didn't require religious or any other conscientious exemption. And this discussion on Twitter included a number of different categories of people that you can see in the different colors. Each circle here is one individual Twitter user. The size of that circle is essentially how many followers they have. The connections between them, the lines that you see, are the number of times that essentially that they are referring to each other. That might be retweets, that might be using the @ sign to speak directly to one another. And what you see is an interconnected conversation between different stakeholders. Now, the stakeholders here at the bottom, now this is the autism community on Twitter, which is pretty cohesive, as you can see in yellow. The anti-vaccine community in magenta here is pretty well connected to the autism community. As you are probably aware, there's a lot of rumors that have so far been unfounded, trying to connect vaccines as the cause of autism. Up in this corner, the blue, this was 2015. So this was a medical freedom contingent that was just starting to grow at this time. And on the right here, this teal was the Tea Party. And so you can see there's a lot of connections between these groups, as there's a lot of kind of issue congruence between people who are not excited about vaccination, who don't believe that there should be restrictions on whether or not people decide to get vaccinated or not. And my goal here is not to take a position in this argument as much as to point out that this group over here, this green Madagascar-like island off in the corner, filled with small circles that don't seem to connect to the rest of the conversation, this is the public health community. These are the people that are pro-vaccine. So as a physician, I look at this and I say, why aren't we part of this conversation? My job here isn't to twist people's arms and make people get vaccines, but my job here is to try to understand how this discourse is taking place, what enables this discourse, what are the structural components that enable the discourse essentially to completely exclude physicians and public health professionals. And what are we doing as physicians and public health professionals to exclude ourselves from these discussions? Now, you might have think I'd cherry pick just one example from 2015, but repeated studies of social media on Ebola, other vaccines, and Zika have shown that the public health community tends to be both peripheral and relatively not influential to these online discourses. Now, this is part and parcel of what Neil Johnson, a physicist at George Washington University, called the distrust ecosystem. Now, he's done a number of studies, which you can see at the bottom of your screen, that looks at hundreds of millions of users on Facebook and the dynamics of pro and anti-vaccine views shared through anti-vaccine networks on Facebook. And he's shown that these networks are surprisingly durable and infiltrate a number of different communities on Facebook. And he's shown in his most recent study in 2023 that post-pandemic, these anti-vaccine communities, their discourse interconnected multiple non-vaccine topics and geographic scales within and across communities. This interconnection confers a unique, a systems level at the scale of the full network, resistance to mitigations, targeting isolated topics or geographic scales, an approach many schemes take due to constrained funding. And I say this because, as I mentioned at the beginning of this talk, the funding for my work comes from the Robert Wood Johnson Foundation, a health funder. So my work needs to be focused on the United States and on health topics. But Neil Johnson's work shows that as we are trying to address the challenges of information distortion, This is happening within and across communities. This is happening on multiple vaccine and non-vaccine topics. This is not simply a health problem. This is an infrastructure problem. And my work is trying to address that. But I think one of the things that we're confined by is the funding structures that we have, both in NIH and elsewhere, that are very siloed. And yet the problem reaches across silos. It's also a problem of social determinants of health. And we probably all recognize social determinants of health as a number of our patients come into the hospital or to the clinic with a lot of challenges related to these social determinants of health. And Medicare is starting to require social needs screening along these social determinants of health. These are things like education, access, and quality, economic stability, social and community context, the neighborhood and built environment, healthcare access, and quality. I'd like to argue, and I'm not the only one here, that information is a determinant of health, because information informs all 5 of these social determinants of health, and people's behaviors related to these 5 social determinants of health is all dependent upon the information that they consume, the information they have access to, and the information that they're exposed to. So as the authors of this paper report, information directly and indirectly affects health outcomes via several routes. And I like to point out that this isn't just me that thinks this. So Garth Graham is someone, he's essentially the chief medical officer at Alphabet, which governs YouTube and Google. So the authors of this paper all work for Google, YouTube, and Alphabet. And so this is something that our technology platforms are recognizing, that information is a determinant of health. It's time for the health community to also recognize this and use the skills and the knowledge that we have accordingly to address this problem. Because I think we're a little bit stuck in medicine in what I describe as message-based health communication. And this will look familiar to, I think, to a lot of us, because it depends on science and scientists. We spend a lot of time in the laboratory trying to develop exactly what the science is. How do we understand H5N1 as it circulates? We develop scientific advisory panels to try to develop guidelines that we publish in scientific journals and preprint. This is part of our normal process of doing science. But then we disseminate that science to public health practitioners, to healthcare workers and clinicians, with the hope of sometimes using the media and journalists, but the hope of ultimately disseminating this to the public so that people incorporate this information into their knowledge, and that knowledge then affects their health behaviors. Things like quitting smoking, things like asking people to exercise. This message-based health communication has worked very well when we had communication structures that facilitated broadcasting very well-honed messages, and where we as public health professionals and physicians could leverage the media and journalists to broadcast these messages to very wide audiences across radio, across television, or even sometimes if we could spread these messages in the clinic. I don't think we're recognizing that the power of message-based health communication, while it still exists, it's vastly diminished. And most people are getting their health information increasingly from networked health communication. A lot of online networks where a lot of the stakeholders in this previously hierarchical model are in this almost egalitarian network where everyone's communicating from one to the other. Now, this is fantastic in many ways, in the sense that, I like being able to tweet at LeBron James if I would like. I also like the fact that I can get information and news and music and art directly from the people that are producing it. I don't need the radio to gatekeep and tell me what music I should be listening to. But the challenge is when it comes to issues that require expertise, when we need people to understand sensitivity, specificity, and positive predictive value, we can run into a lot of challenges where if scientists are talking to other scientists and people overhear those conversations but don't necessarily understand all the nuances, we can have a lot of misperceptions that come out of those conversations. And those misperceptions are not intentional. I'm not trying to say that scientists are trying to mislead people. Sometimes they're just trying to have what is arguably a legitimate scientific discussion. But by having it in an open forum, we can often lead people to misunderstandings. And sometimes, if those misunderstandings become entrenched, it can lead people to health behaviors that are not commensurate with their health goals. So in trying to understand these dynamics, we've written some work about how we can apply a lot of medical, public health, environmental health, and epidemiological principles to address this problem of information distortion. The World Health Organization, for example, calls this an infodemic, an overabundance of information that makes it difficult to tell the veracity, the quality of information. Is this high quality information? Is this low quality information? And so using principles of epidemiology to an infodemic, we can do surveillance of different types of information that are traversing our information ecosystem. We can do a diagnosis, essentially a risk analysis of what are the most dangerous narratives that seem to be flowing. And we can develop response capacities and prevention. This was, I think, a very important aspect of some of our pandemic response in trying to ensure that people who wanted to get vaccinated got vaccinated, and people were exposed to high quality information about vaccination during the COVID pandemic. But I think as we're moving away from the pandemic, while this is a necessary capacity to have, I don't think it's sufficient. And this gets to the title of my talk. I think we need an environmental health framework. So I've borrowed the title of this talk from an article in Columbia Journalism Review by Whitney Phillips, who's a professor of communications at the University of Oregon. She talks about how disinformation is polluting our media environment and facts won't save us. And I emphasize that facts won't save us. This is not simply a marketplace of ideas when the information infrastructure amplifies particular voices and seems to suppress others. So this gets to an important point that we need to start moving away from message-based communication and start thinking about the overall environment and environmental models of information health. Because the goal is not to swat down misinformation and censor it and try to just play whack-a-mole with every piece of false information that's on the internet. But like with other toxins in our environment, the goal is to render it as harmless as possible. And using this lens, we can also apply other principles of environmental health, like toxicological principles. So much of the social science research from behavioral health, psychology, communications, and sociology tends to look at information in a one-off type of perspective, where you expose people to messages, you assess their values, their attitudes, their opinions before that exposure and after that exposure, and you see what impact those bad messages might have had on people, or if you're trying to find remedies to that situation, what good messages can do and what impact they have. I think the challenge of this is, while this is useful to test psychological theories, this does not get at the toxicological principles that we as physicians and public health professionals really understand, is that we really need to be focusing on all of the factors that contribute to someone's dose of toxin. What is the duration of exposure that someone has to information distortion? What is the amount and concentration? What is the route of exposure? And by route, I mean, what is the medium? Certain information might be relatively harmless if it's delivered in text format, but it might be much more sticky and much more psychologically impactful if it's delivered as a TikTok video or on YouTube. That also leads to the question of absorption. How much are people absorbing of this toxic information? And the frequency of exposure. All of these contribute to dose. And there's also a certain degree of individual variability. And as Dr. Williams was talking about before this talk, I mean, I know toxins are kind of a major problem in Louisville with Rubbertown and a number of previously industrial sites. But this is a population level game in the sense that individual variability has a major impact on whether or not people end up coming down with a particular condition. And we understand in a medical environment what are the factors that lead to individual variability: medical conditions, genetics, age, gender, even where people live in terms of sometimes the zip code, what access they might have to green spaces. So between dose and individual variability, we can see toxicity. And these general toxicological principles are something that can also be extended to our information frame. Because anyone that's worked in health understands that dose makes the poison. I can't tell you how many times I've admitted patients to the hospital, and you probably have too, because they said that they have been told to drink 8 glasses of water a day. And one of the first things I say is that is a common misconception, but please do not drink 8 glasses of water a day. When we're starting to think about what can make something a poison, it has everything to do with context and concentration. Water, caffeine, and 1080. These are all various different substances. And there's things that we need to survive, like water. There's things that we like that are entertainment, that sometimes make our life better. That's caffeine. And then there's things that we as a society all agree that should absolutely be quarantined off and put in high spaces so nobody accidentally touches this type of toxic substance. And these could be things like, we all need information in our life to make decisions. So information, just like water, is essential to everything that we do. It's a question of what types of information are we exposed to. We also like information that entertains us. And like caffeine, this can be a very important part of being a human being and living a normal life. But there's also certain types of information. And one category I would say is something like child pornography, that we as a society are all in agreement that we need to quarantine that information, and that needs to be put aside because that has potential toxicity. So taking an environmental health approach means doing a couple of things. It means assessing one's receptivity to finding misinformation credible. It means trying to understand someone's exposure to toxic misinformation. What's someone's media diet, their news choices, their social media use, and then their access to high quality information. Do they have broadband access? Dr. Williams mentioned that Spectrum is down in a part of the city right now. If that's something that happens repeatedly, that's something that's worth kind of reflecting on and considering what access people have to high quality information. There's also the issue of access to health. Do people have access to trusted medical professionals? Who are the trusted community leaders? And are they propagating high quality information? When we start thinking about information in an environmental health approach, we can start to see that all of these three factors start to commingle. And it's important to take an environmental health approach because otherwise, what we can see what happened during the pandemic is a number of public health departments took a little bit of a whack-a-mole approach, as you can see in this cartoon on the right side of your screen, of almost taking this idea that whenever there was wrong information on the internet, we needed to be whacking it down in some way, shape, or form, debunking it. And that's the wrong approach, I think, because we need to take a more modified conception of risk. Not every time someone says something that's wrong on the internet, does it need to be debunked, or do we need to respond? We need to be shifting from atoms of misinformation, so an individual claim, and start thinking about the overall dose that someone might be receiving. And how can we focus on ensuring that people's dose of toxic information is not something that's going to negatively affect their health. It also forces us to move away from intrinsic toxicity of misinformation. Not everything on the internet is as toxic as child pornography. We need to move to a context-dependent analysis. And the analogy I like to make here is lead. So we all care about lead. Lead is extremely important, especially in old houses, maybe in certain parts of the city where there's old houses with lead paint, chipping paint, and are concerned that children might ingest that paint and lead to lead toxicity. But we don't care as much about lead if we find it, say, in the shampoo at a nursing home. And the reason for that is because lead is much more of a neurotoxin in younger populations than older populations. So we adjust our public health response accordingly. So information distortion is also one of these things where we can think about how a text-based or one non-influential person on Twitter who's spreading anti-vaccine misinformation is not something that we should concern ourselves with at all. But, for example, an entire documentary about a conspiracy to disseminate a pandemic is something that can have a lot more psychological sticking power, and therefore requires a different approach to the risk that poses to people and a different public health response. It also allows us to bring in different epidemiological concepts. We can start to think about the population attributable risk of different exposures and different outcomes, including death due to lack of vaccination. It also allows us to bring an equity lens as we start to think about whether or not people have access to broadband, whether or not people have access to health, a concept that some people call digital redlining. It also allows us to think about information deserts and information swamps, which are akin to food deserts and food swamps when we start thinking about people's social determinants around diabetes. Information deserts and information swamps are similar, and there's a vast amount of political science research that shows that in information deserts, in places where local news has died, as the number of local news outlets has declined drastically over the past 15 years, it tends to lead to political polarization. And in randomized controlled trials, they've actually shown that if you can increase the amount of local news in some of those populations, it tends to reduce political polarization. So they think there's a lot of things that we can start thinking about when it comes to information deserts and information swamps that allow us to address kind of some of the inherent inequities in how information, in people's access to information. We can also think about people's receptivity to misinformation. So this is a lot of psychological work done by my colleagues, Sarah and Jack Gorman at Critica, where they talk a lot about bias, confirmation bias, anchoring bias, implicit bias. Biases, cognitive biases is something that in clinical medicine we're comfortable and increasingly comfortable kind of talking about how certain types of biases might be influencing our clinical decision-making. This is something that's not just in our clinical decision-making, but it's in decision-making in general. There's also, among the public, there's often a misunderstanding of causality, risk, probability, sometimes a tendency to avoid complexity, uncertainty. There's charismatic leaders that can lead people down certain paths where they might believe things that they wouldn't otherwise. There's, of course, conspiracy theories. And last but not least, there's ignorance. And I put this last for a reason, because in medicine and public health, our approach is often to take what is called a knowledge deficit approach, which is to assume that when someone comes to us and says something that isn't true, for example, vaccines cause autism, that our approach should be to educate. But it's actually rare that someone is completely ignorant of the information that's out there. There's usually a lot of these other psychological characteristics that are going on that mean that if we provide education, that's probably necessary, but it's insufficient to actually persuade people to our perspective. One of the things that we can focus on instead is prevention. Now, there's a lot of different ways to do this, and I'll mention just a little bit of some of the work that we've done here, but this is not the focus that I want to go down on in this talk, so I'll mention it just very briefly. But there are some potential models for prevention of information distortion in our contemporary information ecosystem. And these are things like information sharing and analysis centers or public health emergency operations centers. And for those of you who are interested, you can check out a paper where we go into these in a little bit more detail in the Annals of Internal Medicine. But in short, an information sharing and analysis center is an infrastructure, often a public-private partnership, but not exclusively, that is designed to help assess threats to critical infrastructure. So there's over 25 ISACs in the United States, and they're around things like aviation, supply chains like pharmaceuticals, election integrity, financial services. There's even an ISAC that's being developed based on a call for proposals at the NSF 6 months ago, asking for the creation of an ISAC to protect research infrastructure in the United States. And these usually have a very interesting governance and funding model that allows kind of stakeholders from a lot of different sectors, the private sector, as well as government as a stakeholder and often a convener, to bring these groups together to help reduce redundancy in both detection and response activities, as well as increase coordination when that makes sense. But the importance here is to make sure that this is not just simply kind of a government activity that's telling people what to believe or what to think, but it is a shared governance model and funding model that is distributed that allows to make sure that no one stakeholder is dominant in this structure. There's also public health emergency operations centers, which the WHO and others have modeled, which are often the convening of very similar stakeholder models like ISACs of public health agencies, UN agencies, academics, donors, stakeholders, the public, technical experts, bringing them all together to be able to coordinate around a specific emergency. And I think these structures can be very helpful as we start to think about how to prepare for and respond to infodemics. But I also think we need to be maximizing exposure to healthy information. And there's some ways that we as clinicians can do this. So one is we have a project that we're working on right now, trying to see if we can take the screening that people do for health needs assessments and social determinants of health at the point of care, and see if we can screen for someone's information environment at the point of care, just like we do for other social determinants of health. There's also, as clinicians, there's a lot of techniques that we can use for communicating about contentious issues at the point of care. And then I'll briefly mention some of the work that we do in virtual spaces with our infodemiologists. So screening for information environments. So over the past decade and a half, there's been increasingly a movement and now a mandate to screen for social needs at the point of care. And I think we can do this to assess people's health information environment as well. We have a pilot project that we're developing where we're just asking people some simple questions of where do you get your health information? How do you decide what or who is trustworthy? And how do you sort between good and bad information? With the goal of understanding someone's individual receptivity and their toxic exposures and access to high integrity health information. Now, this is just a pilot project, but we're trying to build on the decade and a half of literature on other social needs assessments to understand if we can assess someone's risk and if we can develop effective interventions that allow people to align their health beliefs with their health behaviors so that they're better able to reach their health goals. We've written about some of this work here. I'm happy to share this presentation and the references for anyone who's interested, if that would be useful. So I think there's also things that we can be doing as part of these interventions in terms of teaching people to use lateral reading, to check out whether or not some of the sources that they're using are biased. And one website that I recommend is checking on QuackWatch to see if some of the sources that they're using are credible. So this was a technique that I used with the patient that I mentioned at the beginning of this talk who had hypermotility Ehlers-Danlos syndrome, who was following a lot of physicians online who were influencers about this disease. So we sat at the bedside together and we went to QuackWatch and we looked up her influencers and we found that they'd actually been written up by a number of state medical boards. And we had a discussion about, well, does it really make sense to trust them? And this is something that we can work with our patients to show how we, as physicians, check to see what information is credible, and doing some lateral reading with patients as they tell us what information their sources they use is something that might be very effective. There's other techniques for communicating on contentious issues. Now, the evidence is most in support of motivational interviewing. Now, when we think of motivational interviewing is a very common technique that's used at the point of care for assessing people with substance use disorder and assessing their willingness to change. Now, one of the things about motivational interviewing is it's recognizing cognitive dissonance. Now, cognitive dissonance is that situation where someone's health behaviors are not commensurate with their health goals, despite all evidence to the contrary. Someone with alcohol use disorder who's coming in with liver cirrhosis and saying that alcohol is not a problem, they see no reason to change their behavior. When medically speaking, it is very clear that most of their medical condition is related to the alcohol that they're drinking. Now, we have learned through decades of experience using motivational interviewing that directly contradicting someone is more likely to alienate them and precipitate what is known as psychological reactance and alienate them from the healthcare system. Instead, motivational interviewing is an empathic communication approach to try to address people with substance use disorder and other situations where people's health behaviors are not commensurate with their health goals. Now, motivational interviewing has been used in situations to try to address vaccine hesitancy. There's randomized trials in Quebec and across Canada that have shown significant increases in vaccine uptake among postpartum women and significant increases in the number of children who are up to date on their vaccinations, as well as concomitant decreases in concerns about vaccination when using motivational interviewing at the point of care as postpartum women are leaving the hospital. So motivational interviewing has a lot of data behind it and has been used even for COVID vaccine hesitancy. This is something that's been shown to help reduce hesitancy about vaccination, but do so in ways that don't precipitate a backfire effect and make people feel alienated from the medical system. So if there's anything you take away from my talk today, it's when you find yourself in a situation where you're dealing with a patient whose health behaviors are not commensurate with their health goals, and you find out that there's certain medical misperceptions that they might have that are leading them to take those behaviors, the approach that is very strongly recommended is motivational interviewing. There's some other techniques that are under investigation. One is danger talk. This is an approach that is suggested by Lisa Harris, who's an OBGYN at the University of Michigan, who's done a lot of work looking at the controversies and the discussion in clinical settings around abortion. Now, I'm not necessarily using this advice to tell people how to talk about abortion. I am not an abortion provider, but this is something that, because abortion is such a contentious issue, the discussions around it, what we can glean from those discussions is something that we can apply to other contentious issues. So there's some pilot projects to look at whether or not the principles of danger talk about acknowledging the complexity and the nuance of the situation, that there's no one size fits all to this situation, and that clinicians, we can retain trust by emphasizing our role as a clinician, our fiduciary role in trying to make sure that we're doing the best by our patient to help them reach their health goals, and that we're trying to do so amidst the patient's unique clinical circumstances. So these are things that are very important, avoiding political shibboleths, for example, saying things like, you should get the vaccine or follow the science. These are things that the data is starting to show that we should avoid those types of shibboleths when we're talking to patients in clinical environments. And danger talk suggests that we should actually acknowledge that there's complexity and nuance, that you know, in your clinical situation, in my look at your chart as your physician, trying to make sure that I'm doing the best for you based on all of your other underlying conditions, this is what I recommend. This type of approach is currently being assessed outside of abortion providers, and whether or not this type of approach can be used to help increase confidence in vaccines and other types of behaviors such as medication compliance. There's also some discussion in the sociological literature about mammography and interventionists for skeptics. And some of you might be familiar with the fact that mammography guidelines keep changing, including last week. They just recently changed, suggesting that all women should now be screened at 40 and every 2 years thereafter. But this is an ongoing debate. I'm not going to weigh into that debate here, but this is a contentious discussion. And some literature in sociology by Asia Friedman talks about how there's data that supports both camps. It really comes down to a question of risk tolerance under uncertainty. If you're an interventionist, what type of errors do you prefer versus if you're a skeptic? Do you prefer type 1 error or type 2 error? Are you more concerned about false negatives and missing cases of cancer? Or are you more concerned about all of the sequelae that might come from false positives and the iatrogenica from following up cases of potential cancer that turn out to be nothing? And what the sociological literature shows is that these are essentially different cultures that are divided upon where someone's tolerance for risk is in the setting of scientific uncertainty. And that means we as clinicians can use a lot of the literature around cultural humility to recognize that we might be working with patients and trying to help patients that actually are at a different threshold of risk tolerance than we have as a clinician. Now, there's increasing literature on this, both in the medical literature and the sociological literature, and I'm happy to point to more on this. But again, I do want to emphasize that the most evidence is behind motivational interviewing. I do also want to emphasize that there's evidence here. Now, this is also these types of communication techniques. When we talk to the gurus and the really established physicians, kind of the champions, the people that we look up to for some of the most salient clinical advice, this is often something that's ascribed to the art of medicine. But I want to emphasize that a lot of our social science and behavioral science can allow us to bring some of that out of the art of medicine and into the realm of evidence. We don't just have to rely on what the eminence of medicine tells us. We can actually use a lot of evidence to guide what our communication approaches can be. Now, what we're doing is we're developing infodemiologists to try to do this. So if epidemiologists respond to epidemics, infodemiologists respond to infodemics. And this is an infographic that was developed by one of our infodemiologists that shows that our infodemiologists are working in virtual spaces exclusively. And they are people who are drawn from the communities in which they are intervening. And a lot of these conversations in online settings are pretty acrimonious. So our goal here isn't to twist people's arms and change people's minds or sit there trying to, again, we're not trying to swat down every piece of false information that someone might find on the internet. Instead, what we're doing is we're using the communication techniques that you can see across the bottom of your screen. And we're using empathy, we're using evidence-informed techniques, and we're trying to elevate the level of discussion in these online forums. Because we're trying to make sure that people do not succumb to what is known as the illusory truth effect, where if you just see something repeatedly, you start to actually believe in its credibility. So we are trying to disrupt a number of the psychological phenomenon that we see in some of these online environments. Now, in our work in developing infodemiologists, we've noticed that they take on a number of different roles in these virtual settings. They often act as hosts, where they're establishing norms or setting a discussion agenda. They're moderators because they're jumping into and shaping conversations that are veering outside of community norms. And this is why it's very important that they come from the community itself. These are not outsiders that are telling people what to believe. These are people who are part and parcel, who are shaped by that community, who are just trying to have discussions about kind of what is most important to that community. They're often translators because sometimes they're reframing different information that might be seen as threatening. And they're trying to promote engagement and understanding instead of divisiveness. They also role model decision-making. They role model how they communicate through empathic, non-judgmental listening, but they also role model how they manage scientific uncertainty according to community values. So these are things that our infodemiologists are doing, developing community-oriented motivational interviewing. And for anyone who's interested, you're more than welcome to read some of our papers on this topic, and I'd be happy to share this with anyone who would like to dive deeper. But if you want to take one thing away in terms of what we're doing, we're recognizing that most of our public health infrastructure, including our community health workers, are geographically based. But in a world where networked health communication is becoming increasingly prominent, we do not have any health ambassadors for this virtual world. We don't have any community health workers, and we don't have any public health department that is specifically focused on online environments. We're essentially requiring public health departments in every geographic area to try to turn towards the internet, which does not have any geographic boundaries. So what we see is we see the community boundaries as one place where our infodemiologists can work to intervene, essentially to be the community health workers for online communities. So in the end, I hope there's a couple of things that you take home from this talk. One is that information environments are a fundamental social determinant of health. Second is that misinformation is only one piece of the puzzle. We need to be thinking about an environmental approach that helps address the larger issue of how information can become distorted as it traverses our information ecosystem. Medical misperceptions manifest in a number of ways and can lead people to health decisions that are at odds with their health goals. And there are various different effective responses that are being tested. But at the point of care, we really need to focus on patients and focus on motivational interviewing. That's where the best evidence is. So a couple of references. And again, I'd be happy to share this talk with anybody and happy to talk through more. I know this is somewhat of a challenging and controversial topic. And so I hope we have a little bit of time for discussion, and I can stay on a little bit after 9 a.m. as well if necessary. So with that, please feel free to email me, and I'll stop sharing my screen so we can have more conversation.
Thank you so much, Dr. Scales. Dr. Kingery, you want to take over the discussion? And I always have a question. It's always on nutrition, but so maybe I'll just go ahead and start. We have a lot of, in my particular area, which is nutrition prevention, and it really isn't just nutrition. It's sleep and substance avoidance and having a good social environment and social connections. We have evidence on all of this, so-called lifestyle medicine. And yet, when things happen, like what we were discussing ahead of time, when we were talking about toxins and the New England Journal of Medicine article on beginning of March about microplastics and nanoplastics, that goes into the New England Journal of Medicine. And then where does it go? You have a handful of people who pick it up, but it's not really getting to the masses. It's not changing fish consumption or other seafood consumption. It's not changing the way we behave. We're just accepting the fact that there's peer-reviewed science that there's a 453% increase in heart attack, stroke, and death if you have that in your plaque. And how does that information become actionable to help populations and say, until we clean up our oceans, we're not eating seafood anymore. Stop recommending a Mediterranean diet, that sort of thing. How do we do that? I remember the days when it took 17 years to get statins into the mind of cardiologists. I mean, we have to be better than that.
Thanks, Dr. Williams. That's a really important question. I think right now we're in a little bit of we're struggling because right now we are dependent upon a lot of local authorities to do a lot of this communication. There have been, through the pandemic, a couple of communications consortiums, such as the Public Health Communications Collaborative, that came out that is trying to offer a little bit of a scaled method of communication, where they're trying to understand kind of what are the things that need to be communicated to different stakeholders, whether that be public health professionals or the public, and they're sending out to a lot of their stakeholders suggested messaging that people can use. And I think that's a really helpful approach because local public health departments don't have the capacity to be reading every article that comes out in the New England Journal of Medicine and be developing public health messaging based on it. And so the Public Health Communications Collaborative is trying to use a little bit of this kind of, I described this almost ISAC-like model or a Public Health Emergency Operations Center type model to ensure that there's an economy of scale when it comes to communicating these things out to different municipalities. Because this exact issue of microplastics is something that we looked into. To give example, we got our first grant from the Robert Wood Johnson Foundation to address misinformation in November of 2019. So it was a couple of months before the pandemic started. It was actually, the grant was funded to study how to address misinformation about water quality. Because water quality is a major concern in Flint, Michigan, in Newark, New Jersey, and a number of rural areas that have a certain amount of radon exposure. But there's 50,000 municipal water departments in the United States. And in the vast, vast, vast majority of them, they do not have any problem with their municipal water supply. However, with the issue of microplastics, these 50,000 municipal water departments are tasked by the Biden administration to now communicate the risk of microplastics in the water to all of their consumers. Now, this creates a huge communication challenge and one that all 50,000 municipal water departments are very ill-equipped to handle. So I think one of the things that you're pointing out, Dr. Williams, is it's not just this 17-year problem of getting good evidence out into practice, but our communication infrastructure is dependent on our public health infrastructure that is very localized. And while that's excellent in the sense that local people communicating to their constituents and their consumers can do it in ways that their constituents and consumers are going to understand. However, in terms of kind of knowing what messages to disseminate, it creates real problems for scale. And so I think we're starting to see some change in this direction, but it's in very early stages. And I think we need to move much more quickly.
Dave, I'll throw a question in as well. First off, we need about 1,000 clones of you because this is amazing and we need it everywhere. But I'm going to go a little bit even more controversial. You took it to the first step. Maybe I'll go to the next step. Is do you ever worry? I'm sure you do. And can you speak to it a bit about the weaponization of understanding information? So it sounds great to start to understand this. But what happens when the bacon producers or whatever Doritos company starts hiring infodemiologists and start using the structures that you're talking about the other way? Do you worry about that?
I do, Justin, because it's already happening. And this is something that has been shown kind of a number of kind of almost a corporate playbook when it comes to things. We've probably all heard about kind of how smoking did this. There's a fantastic book called Pushing Cool by Keith Weill, who's a history professor at Princeton, who shows how this was a really important factor in disseminating smoking, especially menthol cigarettes among urban African American men. But this is something that has also been seen around climate change and around asbestos, even by people that you wouldn't necessarily expect it. We often have the stereotype of Canadians as being kind of the nicest, kindest, gentlest people, but Canada has actually been a disseminator of disinformation about asbestos and has been an obstructor to international negotiations to ban the sale and trade of asbestos, essentially because there's a lot of voters in Quebec, and in Quebec, there's a lot of asbestos mines. And so only recently that changed. And so this is something that we've seen ever since kind of the 1950s with smoking. Every decade we see this. And I think the difference that we're trying to do is we're trying to make sure that some of this information is put out publicly, where a lot of these campaigns, and there's a number of corporate entities that already have disinformation campaigns and market themselves as able to sway public opinion in their direction. And I think right now, by taking a little bit of a laissez-faire attitude about kind of the assumption that there's a marketplace of ideas, what we're really doing is just allowing a lot of these interests to use these levers to push public opinion in the direction that allows them to maximize their interests rather than the public.
I'll open it up for other questions.
Okay, just real quick, there is a question from I see Dr. Bishop's going to hop on, but I want to get this one from Dr. Robert Emmons, who's one of our hematologists or in our blood and marrow transplant group. He said, Jonathan Haidt has written extensively about the phenomenon of confirmation bias in all humans' decisions, including health issues. How do we include more stealth interventions as he proposes for our deeply held beliefs that resist information and discussion?
That's a great question. I think Dr. Haight's work is really interesting and really thought-provoking. He has a book that recently just came out about cell phone use among children. He's a psychology professor at NYU. One of the things that I think Dr. Haight does is he sometimes focuses a little bit too much on one particular problem when the problem is a little bit more complex. But I do think he is right about the idea that there can be stealth interventions. I think there's a number of things that have been shown kind of in the behavioral economics literature when it comes to nudges that can help people make the right choices along certain approaches. And this gets Dr. Williams a little bit to some of the work that you're talking about with lifestyle medicine of what are some of the nudges that we can do to help people make healthy choices around their nutrition, right? Things around diabetes. This is trying to ensure that people are making the right choices when they're making consumption decisions. And I think this is something that we think about a lot when it comes to diabetes. We haven't thought as much about when it comes to information. And I think that's actually really crucial. There's a number of other countries that do this. And one of the ways that they do this is by putting a lot of emphasis and support on publicly supported independent media, not so that there's essentially kind of a Russia Today, for example, or a propaganda outlet, but it helps try to kind of put a thumb on the scale in terms of high quality information that's out there that makes it just a little bit easier for people to make the right choice when it comes to the information that they're consuming. And even if they're not making the right choices, just a greater chance that they're overall exposed to higher quality information. And I think those are things that we need to be emphasizing along the lines of some of Dr. Haight's stealth interventions.
Dr. Bishop, you have a question?
Yeah. So on the point that you just mentioned, it feels like we need nutrition facts for sources of information that kind of can tell you the high quality or the quality of the information. I thought it was interesting. Yesterday, I reviewed abstracts for the AAP national meeting, and they had a news section that specifically asked if each submission was newsworthy and should be brought to the attention of the public. And they would push it forward to their daily press conference and their online media to try to, I guess, get it out of our just academic circles. So I think it's a small step, but we're already reviewing for, peer review to go to academic world. But how do we start to do this under the direction of our information specialists in all of our societies. We're doing the work anyway, and we're trying to find the Venn diagram of how we can educate and teach and research and kind of hit all those points. But now we need to add this extra circle in of how we communicate it to the public and do it in a way that doesn't alienate them. So this has definitely helped me with the lens in which I think about the work I do.
That's fantastic. And Dr. Bishop, the thing I would add is I think that's essential because a lot of the work that is getting out there is sometimes disseminated by folks with a different agenda, like the one that Dr. Kingery was mentioning. And I think it's important for us as physicians, as scientists, as public health professionals, to recognize that science doesn't speak for itself. I was trained in a laboratory where I was trained that good science speaks for itself. You publish the paper and then you let it go. The laboratory where I learned that was actually Drew Weissman and Katie Caricos. And so one of the things that it did work out for them, but it does, even they talk about the challenges they had in trying to get people to talk about mRNA and mRNA vaccines. And I think this is the lesson that we need to keep learning as scientists. And it's wonderful to hear that ACP is starting to kind of recognize and bring in kind of a strategy for communication, even as this is happening. I think one of the challenges that we face, though, is because as we're communicating more and more in these public spaces, where science is at kind of the cutting edge of discovery, it makes things increasingly uncertain. And what we haven't really figured out is what are some of the best ways to communicate about that uncertainty to make sure that people don't come away with misperceptions. And so, I mean, that's kind of, to me as a researcher, one of the major challenges. But I think we as a profession need to be doing this. Otherwise, malicious actors are going to be creating the narratives, and then it's a lot harder to catch up.
Yeah, I'll give you a real world example. When Drew Weissman came and talked to us at Cornell, I think you were probably there. I talked to him for a while, and he gave the story that when they released their first big paper, right, they found out about the mRNA and this and that. They all gathered around the phone the next day because they were certain the world news was going to call them. And then it was 6 months of crickets, right? And so they had to figure out then, how do we spread this information to the world? Because we know it's important. And we thought we were going to be fielding calls from all over the world, but nothing came in.
So I do see one more question in the chat. I know we're a couple minutes beyond the hour, and we have the Cardinal Minute, which is going to be so important. But it's from Dr. Dio. Thanks for the presentation. It's apprehension. Is apprehension in general society related to the historical trend of recommended guidelines that may later be retracted by the medical society based on new information?
This is a really important question. There's some literature that deals with this. I don't think, Dr. Dio, I don't know if I can specifically say if the apprehension in general society is related to that, but I can say that the public health community and some social science literature is recognizing that a lot of this medical whiplash, what some people call it, where guidelines are being reversed, it can lead to a certain amount of undermining of trust. It's similar when sometimes scientists are kind of debating and discussing on Twitter, where they're having what are completely legitimate scientific discussions, but having it in a public forum seems to undermine trust. And the analogy that I gave is when I work in a hospital and I'm working with consultant services, we debate, we discuss, sometimes we disagree about recommendations between kind of the neurologist or the gastroenterologist or the nephrologist. With often that joke that we have of which is more important, the heart or the kidneys, between the cardiologist and the nephrologist. We have these debates, but they're all behind the scenes. And we do that not because we're trying to exclude the patient or because it's disrespectful to this patient, but we do that because we recognize that when things are uncertain, we need to have a place that we can discuss and iron out some of that uncertainty before we go to the patient and either present choices, present some of that uncertainty, or present a united front. And I think this is a really important point that when we're working in clinical spaces, we intuitively, it's part of professionalism to make sure that we have separate places to discuss some of the detailed debates, the inside baseball, before we bring those debates to the patient. But this is not something that we do kind of with science when we're communicating to the public. And I think it's a really important thing because it seems to undermine trust. And if this is of interest to you, Dr. Dio, there's a great book by Adam Sifu and Vinay Prasad called Ending Medical Reversal, which takes an evidence-based approach to trying to figure out how we can end some of that medical whiplash.
Thank you. Thank you very much. Basically, what brought the question was the recent comment that we've always recommended Mediterranean diets and fish and, as a healthy diet. And now we were talking about retracting that because of the presence of microplastics. So this happens a lot where, a recommendation is given and then 20, 25 years down the line, things come up and we either alter or retract it completely. And I think that is probably one of the main contributors from what I see in my patients when they come up with their arguments about not wanting to follow certain guidelines.
Absolutely. And I think one of the challenges that when we talk to a number of people in this field, when we're trying to communicate, there's a certain level of scientific literacy that we as physicians have, where the guidelines change and we look at the data and we see the nuance of like, well, the guidelines change not because the Mediterranean diet is bad, but because fish in the Mediterranean diet are contaminated with microplastics. We understand that nuance and we understand that as new science comes out, guidelines are going to change. One of the challenges that I think communicators face is being able to effectively communicate is dependent upon the level of scientific and overall literacy in the population. And so this is why one of the things, why am I working on this? Is, as Dr. Kingery said, I was working in global health before this, but I've moved over into this space because I see this as a generational issue where we need to be working to try to increase scientific literacy, try to be working kind of at social determinants of health to address this issue. And I think it's going to take at least a generation before we really start to move the needle on it.
Well, thank you. This discussion could go on for a very long time because there's so many good examples of where the science changes. And whenever I'm rounding, I remind my house staff, if I haven't looked it up in the last 18 months, I don't believe it because so much, and particularly in my field of cardiology, is completely changed from what I learned. The only thing I learned is how to learn. Okay, that's the facts were actually wrong. So I really want to thank you. And if I can keep you and Dr. Kingery on, we can do our Cardinal Minute. Get a really wonderful summary. There was a comment by Jessica Petrie that I should read out. Just a reminder that our librarians actually help collect information for evidence-based practice and can focus on the interpretation and appraisal of that information. And so there's a nice link that she has in the chat. And to remind folks that we do have sort of evidence gathering services here at the university. And with that, just want to thank everybody, and I'll see you all at noon for our research grand rounds, and look forward to having that every week. And I really appreciate all of the learning that we've gotten. This has been an amazing, thoughtful grand rounds, and hopefully it'll stimulate a lot of action to try to get our informatics to the point where we can actually make them accurate and actionable. If we could do those two things, that'd be great. All right.
I want to real quick say thank you, Dr. Scales. Thank you, Dr. Kingery, for helping facilitate this outstanding talk. And Dr. Scales, before we go here, I'll mention the Cardinal Minute segment in just a moment. We have a little tradition here with the UofL Department of Medicine for our Grand Round speakers, and we like to get our guests a little gift for speaking, and then that's synonymous with the city of Louisville. And so you will be getting your very own personalized Louisville Slugger bat.
Okay. That's fantastic.
Yeah.
I'm a big baseball fan, so that's very kind.
Excellent. Mets or Yanks?
Braves.
Oh, okay. Oh, well, okay. Good choice.
Absolutely.
All right. So thank you, everybody. We'll be back next week with Dr. Abigail Chan from the Division of Medical Oncology and the Cancer Center and the Brown Cancer Center. And we'll see everybody next week, and hopefully see a bunch of folks at noon. So thanks a bunch.